There are so many treatment options for inflammatory bowel disease, but with few head-to-head trials available, which is the best medication for my patient? Welcome to GI Insights on ReachMD. I'm Dr. Peter Buch, and today we're joined by returning guest Dr. David Hudesman, who will explore this topic. He's a professor of medicine at NYU Grossman School of Medicine and director of NYU Langone's Inflammatory Bowel Disease Center. Welcome back to the program, Dr. Hudesman.
Thanks so much. Happy to be here.
So, Dr. Hudesman, let's get right to the heart of the matter. Without adequate comparative studies, how do you make medication decisions?
So first, I think this is a great time for patients that we have so many more different therapeutic options now. We had just 5, 6 years ago, and I feel like each year more therapies are coming out with newer mechanisms of action. Saying that, it's difficult then is how do you pick that right therapy for that right patient? And unfortunately, even though there's a ton of research being done, including what we're doing at NYU, trying to find some type of biomarker or companion diagnostic that could say, with this therapy, you're 90% likely to respond, and with this therapy, you're only 20%, we're just not there yet. So it's really combining the head-to-head trials we do have, which is 1 in ulcerative colitis and 2 in Crohn's, and some comparative effectiveness trials, and then just our experience and real-world evidence. And then, of course, talking to the patient and having that shared decision-making discussion.
So when assessing for onset of action in Crohn's disease, which medications are the fastest acting?
This is an important question when selecting therapy is how active are your patients, right? And some of our therapies now work very quickly where we can minimize steroids or even maybe avoid steroid use. I still think for Crohn's and with ulcerative colitis, our fastest acting medications are infliximab and upadacitinib. So our anti-TNF infusion and our selective JAK1 inhibitor works very quickly. Within a week, you could see response with both. Also, there's always delayed responders, right? So patients that could take a month or 2 for them to respond, but as early in less than a week, you could see response with both infliximab and upadacitinib.
And when considering serious risk of infections in Crohn's disease, which medications are the safest?
So first, when you're talking about infections and other risks, there's risks of the medication, and then there's risks of not putting patients on appropriate therapy. So risks of the disease. So if you look just at the data from these large-scale clinical trials and other evidence, the higher rates of infection and the higher rates of serious adverse events is more associated with ongoing inflammation than it is with actual medical therapy. So I think, number one, you want to pick the therapy that's going to work for your patient. Now, let's say you have a handful of different options that you think are going to be efficacious. The more targeted therapies tend to have the lower infectious side effects. Before I go into those therapies, though, I do want to emphasize the fact, and when I speak to my patients, I start saying all of our therapies are safe. I'm not going to talk about any therapy that's not safe. Some have more potential side effects than others, but these are also very small risks and very safe therapies. Now, saying that, our most targeted therapies are vedolizumab, or our anti-integrin, and then our anti-IL-12/23, ustekinumab, and our selective IL-23 inhibitors, which now include risankizumab, mirikizumab, and guselkumab. So in my mind, those therapies are most targeted and have the lowest infection risks.
Now, how does disease location in Crohn's disease affect the choice of medications?
So we're going to be seeing more data on this in the next few years. I think we're going to be treating Crohn's colitis more like ulcerative colitis, right? So what I'm saying is that small bowel Crohn's is a different beast than colonic Crohn's, and probably colonic Crohn's is more similar to ulcerative colitis. Again, if we're talking about routine, moderate to severe disease, I don't think it matters significantly whether it's Crohn's colitis or Crohn's ileitis. However, if you have these deep small bowel ulcerations, if you start having penetrating or stricturing complications, that's when I'm going to lean towards an anti-TNF like infliximab, upadacitinib, or start talking about surgery. So that's when I'm getting a little more concerned. Those are the more high-risk patients, those deep ileal ulceration patients.
For those just tuning in, you're listening to GI Insights on ReachMD. I'm Dr. Peter Buch, and I'm speaking with Dr. David Hudesman about choosing the best medicine for our IBD patients. So if we continue with the Crohn's theme, Dr. Hudesman, what are your first-line choices in biologic, naive, moderate to severe illness patients?
So the way I look at this, so in my bio-naive patients without extraintestinal manifestations, without complications, I think all of our current therapies have a good chance of working. And if you actually look at the data, it's really timing of starting therapy, right? So if you start a patient on appropriate therapy within a year or two after diagnosis, you're much more likely to have higher response, higher remission rates than if you wait 3 years, 5 years, 10 years and cycling through steroids. Saying that, since all of our therapies would work in this situation, usually I talk about what are the most targeted to minimize risk, and then what's the most convenient for the patient. And then we talk about other factors that might be important to patients, their lifestyle, their jobs, and so forth. So usually in my moderate to severe patient without complications, I'm starting now either ustekinumab or a selective IL-23 inhibitor.
And how do your recommendations differ for ulcerative colitis patients?
So for ulcerative colitis, same concept. If you're on the more moderate end of the moderate to severe spectrum, I think all the FDA-approved therapies will work. So it's really talking with the patient and sort of minimizing risk and what's most convenient. So I think the selective IL-23 inhibitors and ustekinumab are great options, and I use them a lot first line. I think vedolizumab is a great first-line option. I do use it, just to go back to Crohn's and Crohn's colitis. I don't use it as much in small bowel Crohn's, but for ulcerative colitis, I use a lot of vedolizumab. And then I think this is where the S1P receptor modulators, such as ozanimod and etrasimod, play as well. So for ulcerative colitis, S1P receptor modulators, vedolizumab, and the IL-12/23 selective IL-23 inhibitors, first line. For Crohn's disease, I'm mainly using the selective IL-23 inhibitors, also some ustekinumab, and if it's Crohn's colitis, I'll use some vedolizumab as well.
Now, Dr. Hudesman, we're almost at the end of our discussion, so are there any other insights you would like to share?
Even though we have multiple therapeutic options right now, it's important that we set a target. So before starting somebody on therapy, what is that target going to be? Is it going to be healing, right? Is this somebody that we think we could achieve that goal? And we need to monitor them. So we're monitoring them not only based on symptoms, but based on biomarkers such as CRP or fecal calprotectin. We do intestinal ultrasound. That's another nice way. And we can repeat a colonoscopy. Even though we have many different therapies, I still try to optimize therapies as best as we can before switching to something else. And then I just want to highlight one study. We talked about first-line therapies, but for second-line therapies, there was a study relatively recently published called the Sequence, which was our most recent head-to-head trial, showing how risankizumab, one of our selective IL-23 inhibitors, outperformed ustekinumab, IL-12/23 inhibitor, when you're using this second line after an anti-TNF. So we're starting to get some more data on how to position therapies, but not only first line, but second and third line.
What great insights on choosing medicines in IBD. I want to thank my guest, Dr. David Hudesman, for joining us to share his important insights on inflammatory bowel disease. Dr. Hudesman, it was a pleasure speaking with you today.
Great speaking with you as well. Thanks so much.
For ReachMD, I'm Dr. Peter Buch. To access this and other episodes in this series, visit GI Insights on ReachMD.com, where you can be part of the knowledge. Thanks for listening and looking forward to learning with you next time.